Hello, this is Zahirul Alam. Welcome you all on Frankly Speaking. Our guest today is Dr. Abdullah Baqui, professor of Johns Hopkins University, Maryland, in the United States. Dr. Baqui is a Bangladeshi physician trained in public health and health systems, living overseas for the last 10 years, but continue to work very closely with Bangladesh Health Program. He visits Bangladesh at least 4 times a year. For the last 25 years, he has been conducting research to develop simple, cost-effective interventions to improve health and survival of children in Bangladesh and other poor countries. In the last 10 years, he has focused his efforts primarily to improve health and survival of neonates because child survival has generally improved, but deaths in the first month of life remained very high. We welcome Professor Baqui on Frankly Speaking.
Thank you, Dr. Mr. Johid.
Professor Baqui, we're very proud that you are a Bangladeshi national and working in the Johns Hopkins University for long years. At the very beginning, what I would like to know from you that it is estimated that 10 million children die every year around the world,
right.
And most of them is in the developing countries, in the poor countries like Bangladesh or other developing countries. And statistic says that more than 27,000 children die every day. The staggering numbers of premature deaths are simply, definitely, we would say unacceptable. Right. And you are conducting research on these issues. What is the scenario currently around the world and also in Bangladesh?
You know, over the last few years, really the last decade or 2 decades, child survival improved. But still, like as you said, globally about 10 million under 5 children die every year.
10 million?
10 million. That's a lot of death. And many of them die from causes that are preventable. And
what are the major causes?
I think about, of those 10 million deaths, and globally about 4 million, that's 40%, die in the first month. We call them neonatal death.
Okay.
And I'll talk about that maybe in a minute.
Okay.
But also another 20% of those 10 million deaths occur due to pneumonia,
okay.
And another 20% due to diarrhea.
Okay.
And so basically we have the technology or interventions to prevent most of these deaths.
Okay.
Deaths from pneumonia, deaths from diarrhea.
Okay.
And as I said, of course, the deaths have been coming down more rapidly in older children, but not so rapidly in young children, particularly in the first month of life.
Okay. What are the research you have been conducting on?
You know, I came out of medical school, Dhaka Medical College, back in '77, and joined the Cholera Research Lab, which is now ICDDRB, and in the Matlab station, which is in Comilla. So, and initially I was a physician for a few years, working in a hospital, but realized that really so many children are dying prematurely. So I wanted to focus my efforts to improve survival.
In which area? Diarrhea, pneumonia?
Initial research was on diarrheal diseases.
Okay.
So basically, developed interventions to improve survival of children from diarrhea. And one of those research was to demonstrate that if you use zinc, which is a micronutrient, zinc in diarrhea along with oral dehydration solution, that significantly reduces the severity of diarrhea and duration of diarrhea. Before that, there are a number of studies conducted, but small-scale hospital-based studies conducted. Those studies also demonstrated that really, if you use zinc with oral dehydration solution during diarrhea, it reduces the duration and severity. But those are small studies, like 100 or 200 children. And I thought that really, I think that is not going to change policy. So I wanted to do a large trial in Matlab in about 15,000 children. And in fact, in 30 community health worker areas. So 30 community health worker areas where we allocated them, I think, into some 15 areas we gave oral dehydration solution only. That was the standard of care at that point. And another 15 areas we gave oral dehydration with zinc. And what we really were able to show that, of course, yes, it reduces the duration and severity of diarrhea, reduces hospitalization of diarrhea. It also reduces subsequent incidence of diarrhea or occurrence of diarrhea. What was most remarkable was that we also showed 50% reduction of child death. So I think that was, in a way, I should not say too much about my studies, but it's a landmark study. We published that in British Medical Journal in 2000. It was in British Medical Journal. and then in 2002, and in 2003, UNICEF and WHO convened a meeting in Delhi. I was in that meeting, in fact, and then they looked at all the literature and then changed the global diarrhea case management strategy. And so WHO said that, I think World Health Organization really in fact said that really all episodes of diarrhea should be treated with oral dehydration solution along with zinc.
In terms of reducing deaths out of diarrhea, oral rehydration solution with zinc.
Right.
So how popular is that? I mean, how effective is that along with Bangladesh and the other parts of the world?
Well, I think, I think the irony is really, I think ICDDRB, our predecessor of ICDRB, Color Research Laboratory, discovered oral rehydration solution.
Yep.
And Lancet, in fact, said that that was the most important discovery in the last century.
Last century.
Right. But the irony is really, it's not really used. In Bangladesh, about 50% of the episodes are treated with diarrhea. In many other countries, it's 20–30%. So that's the problem.
Where is the problem lies with?
Well, I think overall, I think the problem is the weak health system. We should talk about that. The health systems in many of these countries of Asia and Sub-Saharan Africa are really weak, and so not able to deliver the tested or proven interventions. So that's the underlying problem. But really, I think an answer to your question about how popular is zinc in Bangladesh, in fact, really, after that change of global policy by the World Health Organization, ICDDRB, with funding from Gates Foundation, started a project called SUZI. That's the scaling up zinc, and that project was quite successful. I think there is a product now available in the market, and the use rates are still not high, but I think it is increasingly becoming popular. I think, but still, like the coverage is low. I think coverage of not just zinc is low, or oral dehydration solution is low. It's low in general for many of the proven interventions.
Is it the same case in other countries, other developing countries?
Many of the developing countries of South Asia, particularly, and Sub-Saharan Africa, and these countries experience the vast majority of the 10 million deaths also. I think. So this is difficult because we know how to prevent death from diarrhea as well as pneumonia, but the problem is, I think, in many of these countries of South Asia and Sub-Saharan Africa, the health system is really generally weak, not able to deliver the interventions with high coverage. But also there are other constraints. I think we have a lot of poverty, people cannot afford to go to the health centers. We have also cultural constraints, I think, particularly when we talk about the newborn health. I think we don't, many mothers of families think that a newborn should not be taken out of home in the first 10 days. So there are many issues. There are health systems issues, and also there are issues related to use of services. I think so. And some of them are cultural, and some of them are economical.
But the economic and the cultural barriers, how to get over all those barriers?
In those scenarios or situations, I think we have a difficulty. I think, and the difficulty is, I think, on the side of the health systems. I think some people call it a supply side issues and demand side issues. You probably have heard about that. I think one is the supply. I think if there's no supply, I think so. Supply side issues, I think, it's a generally weak health system. We don't have enough trained manpower. We don't have. I think we have problems with supervision, support. I think logistics. Essential medicines are not often available. So there are a lot of challenges. Right.
So taking into account the weaknesses, we have a lot reasons to be optimistic for the coming days.
Right. I think we can talk about, I think, the other studies we have done, the Hib vaccine trial, the Haemophilus influenzae type B, which is a bacteria, not HIV.
Not HIV, yes.
And Haemophilus influenzae type B, which is a bacteria, causes pneumonia and meningitis. And I mentioned to you, Mr. Johid, that pneumonia is the number one cause of death in under 5 children, if we take out the newborn deaths. So pneumonia is the number.
Any particular statistic related
like
to Bangladesh?
It's 20–21%.
20–21%
of all under 5 deaths.
Okay.
And diarrhea is about 19–20%. So of all under 5 deaths. So they're really. These two are the most important causes of under 5 deaths. But if you take out the newborn deaths, which is another 40%.
Okay.
But in Bangladesh, it's really kind of 60%. I think because Bangladesh has done very well in reducing deaths in older children, and so but really couldn't do that well in reducing deaths in the first month.
Okay.
So as a proportion of under 5 deaths, newborn deaths is now about 60% of under 5 deaths.
Professor Baqui, before you conducted the Hib vaccine trial in Dhaka, Bangladesh, there was a widespread perception, even among the medical community, that HIV disease is not a problem in the subcontinent. In your study, what you have discovered?
I think pneumonia, as I said, causes about 21% of under 5 deaths, and half of them are bacterial pneumonia. And the two important bacteria that causes pneumonia are Haemophilus influenzae type B and Streptococcus pneumoniae. We have a vaccine, a proven vaccine for Haemophilus influenzae type B. But in 10 years ago, when we started talking about it in this subcontinent, there is as you said, there's a perception that it's not a problem, and there are reasons for it. The reason is really it causes a lot of pneumonia and causes a lot of death, but it's very difficult to isolate the bacteria, and so that was the reason. So what we did is really we really conducted a study in Dhaka city, in fact, and in some 70,000 children.
In which year?
In 2002.
Okay.
And in fact with funding from Ministry of Health.
Okay.
And so basically in some 70,000 children, but really it's about 100 plus immunization centers. So we allocated immunization centers into a standard DPT, half of them, and another half into DPT plus HIV. And then really conducted surveillance and showed that those who received the HIV vaccine along with DPT, they had a 1/3 lower reduction of severe pneumonia.
Okay.
So we didn't look for the bacteria. We did, but we also couldn't isolate a lot of bacteria in the bloodstream. And there are a lot of reasons for it. I think best is not to get to too much technical.
Yes, yeah.
So it was easier to measure the disease after giving the vaccine. And then we demonstrated that really it reduced severe pneumonia by about 1/3. And so that really was very helpful. We presented that data to, of course, to our national government, Ministry of Health, professional bodies, but also regionally and internationally.
So, do you think that Bangladesh government has accepted the HIV vaccine in a routine childhood immunization?
Yes, I think I'm so happy to tell you that really, I think Ministry of Health, government of Bangladesh just adopted HIV vaccine in routine immunization. So I think what will happen is the DPT, which is a 3-different vaccine, will be replaced by a pentavalent vaccine, which will have DPT plus hepatitis B, which we already adopted a few years ago, and plus HIV. So that decision has been made.
Professor Baqui, we came to know that one of your articles, which published in Lancet in June 2008, one of the most respected and valued journal in medical science, the Lancet is, and it was selected as one of the best 3 articles of the year 2008 published in Lancet that was prepared by you. Tell us something about your article.
Well, it's by the team of colleagues I work with. Yes, myself and my colleagues worked on it, and it was the result of like about 7 years' work in Bangladesh, and it's on newborn health. Ministry of Health was very much with us and provided a lot of support and encouragement. ICDRB was very involved in that work, and then NGO in Sylhet. We went to Sylhet to do this work because Sylhet experiences very high mortality.
Okay.
Like Bangladesh has done well in terms of reduction of under 5 mortality and infant mortality, but it remained high in Sylhet division particularly.
Any special reasons there?
Well, I think it's hard to know. I think the cultural issues are very different in Sylhet, but also the health systems is generally much more weak in Sylhet, and so but also it's high in 3 southern districts, including the district of the Prime Minister, Gopalganj, Shariatpur, and Madaripur. And so we decided to work in Sylhet and decided to work with Ministry of Health, NGO, and a premier research institute you have in your country, ICDRB. I started my career there, in fact. Then what we did, the first thing we did is really we spent a year, in the year of 2002, in Sylhet, 3 sub-districts or upazila of Sylhet, and tried to understand what are the problems. why so many babies die in the first month of life. So we have like our workers, many of them are like masters in anthropology or social science. They spend really a year in the villages trying to understand how families take care of pregnant women, how they take care of the delivery process, how they take care of postpartum women or women after delivery and newborn. And many of these things we learned, I think, in fact, I'm a Bangladeshi, I grew up in this culture, are shocking to me, to be honest. I think one of the first thing we learned that really, well, I think there is no planning for delivery, of course. Okay. It's kind of a taboo. You should not do that. I think God will not like it. So that's the kind of feeling. And so there is no planning for delivery. There is no planning for emergencies. And most of the deliveries, of course, take place in a home. 90% deliveries take place in a home and attended by untrained attendant. We call DAI or DAT. So, and then really many of the deliveries are attended not even by a TBA or birth attendant, by a family member with no training. And so, and then the issues of really newborn care. There is no care provided to newborn in the first 15 minutes. Because the TBA, for a very good reason, remained focused on the mother. And so until the placenta is delivered, nobody pays attention to the newborn. Okay. And so if the newborn is delivered with a breathing problem, I think the baby will die. Or the baby is really lying on a floor, soaked, and so they are become more susceptible to infection and coldness and all kinds of problems. The problem with the cord care, the umbilical cord, I think they apply a lot of indigenous substances, like maybe sometime kind of they chew rice and apply that, which is not, of course, very good. They apply turmeric. They apply a lot of different indigenous substances that increases the risk of infection. And so basically, and also there is very little awareness of danger sign in a newborn. The caretaking is very low, partly because of cultural reason. I think there's a belief that babies should not be taken out of home in the first 10 days or 30 days. So it depends on where you are. And also there's a feeling that Western medicine is not very helpful, it's too strong, and so should not be given. So there's a variety of reasons. So what we did is really then we had a week-long workshop, participatory workshop. We invited I think, of course, Ministry of Health, ICDDRB, which are very much part of it, Shimantik, but also other organizations, health organizations in town, including UNICEF, World Health Organization, World Bank, but also NGO like CARE, BRAC. And so together we looked at what we learned, and together we designed the intervention, and with two different components. One is to improve behavior at the household level, to improve care of pregnant women, delivery care, improve newborn care, and the other part of the intervention was to work with the Ministry of Health and improve the services at the facility level, like a family welfare center and sub-district hospital. And so, and we implemented that over a 30-month period and showed a 34% reduction in newborn mortality, which is remarkable in many ways because we, in fact, used NGO workers and government facilities.
Okay, but we are almost to end our program. The last point is we are going to face some challenges, especially meeting the goals or targets which is set by the MDGs called Millennium Development Goal by 2015. So in terms of reducing maternal mortality or child mortality, where we stand now and what are the current challenges and how to going forward?
You know, Mr. Johid, I think you'll be pleased to, I think you may know and you will be very pleased to know that really Bangladesh is one of the few countries that is on track to achieve MDG 4. So, and we have done very well. In fact, under 5 mortality in our country 15 years ago was about 117 per thousand live births. It has come down to 65. That's a 45% reduction. I think so. Really, we are doing very well. But I think there are challenges. The one challenge is really the continuing high mortality in the first month of life. Because globally, it's the death in the first month of life.
That's the biggest challenge, I think.
Right. globally, the death in the first month of life accounts for about 40% of under 5 death. In Bangladesh, it's 60%. And so I think so we have done well in other age groups and couldn't reduce the newborn newborn mortality, in fact. And the good news is based on our work and other work of other organizations, Ministry of Health has developed a neonatal health strategy. And so it will be important to operationalize the neonatal health strategy. A document has no value. It has to be implemented. The other challenge is really, I think I mentioned that the health systems in general is very weak. I think so health systems is weak. The quality of care provided is not good. And so really, and the other issues, like we have a shortage of trained manpower, particularly shortage of nurses, community midwives, and there's a problem of not having adequate supervision, support, supplies of essential drugs. And we have to really, cannot be happy with what we have achieved. We are doing very well.
Should not be complacent.
We have to to keep up that momentum, we need to strengthen the health system. And also, I think often we do things and be happy, but don't look at the results. We should also pay attention to the results. You know?
Well, Professor Baqui, before thanking you and before concluding, I must say that we're really proud of you, that with such a global level of recognition you have earned for your works and the achievement through a Bangladeshi-based project. And your recognition again reminded us that our different struggle, like in 1952, like in 1971, as a Bangladeshi national, we are proud of your success, and we're taking the opportunity to congratulate you for joining us on Frankly Speaking.
Thank you so much, and thank you for inviting me to participate in your stream program. You know?
Yeah, we are very delighted. Thank you, viewers. We welcome you to watch our next episode. Until then, do take care and bye-bye.